Week 8. This week we're going to be going into GIGU. I told you there's a lot of different stuff that we'll be talking about it, and then a lot of similarities. Um, Remember for week 8 that pediatric clinical assessment assignment is due. I have been sending some people have been giving me their stuff. I've been correcting it, telling them what to do, sending it back to get the best grades. Remember, if you do it on the weekend, I'm not going to be as apt to do it as I would, in the beginning of the week or so. The quicker you get it in, the quicker I can help you with that. Because when you have 3 classes, it ends up to be lots of students. Also, it's a pediatric assignment exam. It's a case study. And there's also the NCLEX. Yes, Alea, you have a question?
So can I still submit it between today and Wednesday and you'll grade it into?
Absolutely,
Okay.
absolutely, absolutely, yes. As I'm getting them every day when I sit down and look at the computer, I go through messages and I go through any of those things, and I always go to that column. Has somebody turned it in? Something I need to look at. So yes, absolutely. That was something I promised you the first day of class. So yes, I will. But getting up into the weekend, Friday would probably be the last I really look at it that closely, just to be very honest with you, because then it gets everybody's in there. So let's go ahead. We're going to do our normal things. We're going to first do our PowerPoint, and then it is a pretty long Kahoot. So I'm hoping that I'll be able to get that in. So I actually do it backwards. I do chapter 45 before, which is GU, before I do 41. Why? I think GI can be overwhelming. And then by the time you get to GU, you're like, this is just too much to remember. So I switched it up. So when you think of GU, you think of children. The biggest thing that you see, the common conditions, urinary tract infection. It's very, very difficult to treat urinary tract infections. It's just trying to find out what germs there. I've already gone over this with you where when you're an infant, you don't have immune systems. In the first year of life, we will be doing the catheterization if you go into an ER or an urgent care, because we have one chance to get a good specimen to know what bacteria we're treating and to make sure the antibiotic that you're taking is working. Why take a whole dose of it when it doesn't work? Just to come find out, you need another urinary sample and you need another antibiotic. So that is one of the big things. Uncircumcised boys have a high incidence. And why do you think that? Well, many women, mothers, don't like to pull back the foreskin on a penis because they think it hurts them. And, today they're not doing circumcisions routinely like they did many, many years ago. So many are like, okay, it's, an extra doctor's office, sometimes extra charge. He doesn't really need it. Okay, we're not doing it. But if you don't pull back the foreskin, in between the foreskin and the penis, this tissue called schmegma builds up. And it's where bacteria loves to collect. And it goes up into the penis, through the urethra, into the bladder, urinary tract infection. So, what do we tell our parents? Make sure every day in the bath, pull it down and cleanse it well. If there's conditions that can occur with that, we're going to go into them. Actually, I edited him on this quarter. I only had him on his Kahoot. So we'll be talking about that a little bit later. And the other thing, make sure they take the whole dose. If 2 kids in the family, and it always happens that way, both of them having a urinary tract infection, giving them half doses of each, it's not going to take care of the bacteria. And I've seen that done before. So urinary tract, when do you know? Well, of course, if they're incontinent or if when they're already potty trained, they're holding themselves or wiggling, they're, itching, scratching, that frequency, urgency, and of course, that strong foul smelling urine. We know possibly that's what's going to go on. So prevention is our big key. And the biggest thing is increasing fluids. So urinary tract infection, biggest prevention is fluids. Then, as they are understanding potty training, especially your toddlers, wiping from the front to back. Younger kids don't understand that. So again, it's just again persistent teaching by parents and washing hands, of course. Now, the other thing with adolescent girls, I've seen young adolescent girls come in and they're on their third urinary tract infection. And these are the ones that I try to get. And I usually come to my area where if I work not in the triage area, they'd come over to me. And I get the parents, out of the room and ask them if they are sexually active because they say just urinating after having intercourse can decrease the incidence. And it does because some of the girls I taught that didn't come back again like they were before. So urinary tract infections, we got to diagnose it. Are you in the hospital? Are you home? All of those things make a difference in what type of test we do. Now, a urine culture sensitivity is what we need on especially young children's. As I said, catheterizing is the best. Bagging them is probably the least of all the ones that we would do. But even a urine CNS. I've actually had parents stand their children on the sink or the toilet, have them pee, and then catch it after they've been cleaned to get that clean catch urine. And it works. It can get a little messy, but at least the specimen that we need was good. When they're in the hospital, and especially your young premature infants, there is no catheter small enough to go into their urethra. So they have to take a needle with a syringe and they'll clean the area, sterile gloves, sterile syringe, and they'll go clean it, usually with whatever their cleaning thing is. And then go right above the symphysis pubis, 45-degree angle. And that's where the bladder is. And they only need a little bit, a half ml, a half cc is all they need. And then we put that in the urine cup and we send it. And that's a suprapubic aspiration. That's for your premature infants or your small infants. If we're getting frequent stuff going on, they'll go in, they'll do kidney taps. Maybe the infection's hiding up in the kidney somewhere, or maybe it's a bunch of sludge and it's underneath the sludge in the bladder. They will put a catheter in and they'll wash it out and pull back the liquid and they'll send that also for urine culture, etc. When there's frequent kidney infections, you always worry about structural issues. And that's when we do the voiding cystourethropy. Again, they take a catheter, it's an outpatient procedure. Younger kids get a little sedation only because it's a catheter laying still, right, for these x-rays. But they take a catheter, put it in, and insert a dye in the bladder. And they look to see, does that dye go up the ureters? Does it get into the kidneys? And again, that's showing any structure or any place where it doesn't go. IVP, mostly for your kidney stones. We see that. And usually older kids have the kidney stones. And then, of course, there's all sorts of scans. Now, this is a new slide I added on this quarter because our questions that come up all about the foreskin and the penis narrow, and it's tight, and you can't pull down that foreskin. So the problem with that is that if you can't pull back the foreskin, remember that schmegma that's building up underneath, it's going to come up and get into the urethra, and it's going to go into the bladder. So that is what we call a thymosis. My grandson, born, I could not pull his foreskin down. And slowly I tried, and no. So he had to get a circumcision. That's the treatment for those who you cannot pull down. So thymosis, tightening. Balantitis is when that foreskin, you see it get puffy and it's reddened and it's infected, okay? And there's different ways that we treat things. Thymosis, steroid cream will shrink it, hopefully, and allow us to pull it down. Usually they'll just go, it's male, young enough, is usually when they'll go to the circumcision. So again, always when we're working with pulling down the foreskin, keeping everything clean, make sure that we use proper hygiene. When we're done, make sure we pull that foreskin back up and don't leave it stuck down. because that is the paraphimosis, where it's squeezing the tip of the penis and there's no blood getting there. So those are a couple problems with males and circumcision. Oh, what is a decision? Another thing that can happen is something called a hydrocele. A hydrocele is when we have a child who is the testicles get a little swollen, and usually it gets to the point where now it hurts. It's discolored, and they can do a couple things. Could be due to an infection, or it could be just due to it was temporary. Swelling came up and came down. So when they do the surgery, they'll take and remove the fluid. There's some times where they'll just try to give an antibiotic first. And I've seen that with older children. Sometimes that works, it's all it needed, but sometimes you need surgery. Remember, anytime a boy or girl does anything on their peritoneal area, doing surgery on, you need to protect that area post-op. We're going to go into something called hypospadias, epispadias, hydroceles, even circumcisions. Make sure they're not bouncing on toys, etc. And then, of course, find out when can we bathe that child, okay, and any post-op care with it. So cryptorchidism, this is the male. Testicles are up inside the body, one or two, or partial one, partial two, all of those different things that you can see. Anicharism is when you don't have any testicles, and that can happen. Most of the times we do find them stuck up in there. Now, one of the things about us as nurses, and what are some things we need to remember? We know the testicles with heat will get larger, okay? So if you take an infant, take off their diaper, and this room is cold, the testicles and the testes are going to suck inwards, right? So the best way to examine, in a warmer room. You don't have to wash them with water, none of that. Just a normal warm room, or wait to take off that diaper, which is nice and warm, before we go in there and we go looking for it. Hypospadias, and there's also an epispadias. So hypospadias is the bottom of the penis is where the urine comes out. It's not up here. It's somewhere on the bottom. So it's underneath. It could be right after the tip, or it could be very below. Now, the thing about hypospadias is, if you see that, that's a plastic closure where they fillet the entire penis open, and they need the foreskin. You can't circumcise these children, so we can have it for the plastic closure. So these children won't be circumcised. We usually, right before they're potty trained, we will do the surgery, because we don't want the effect emotionally, thinking about they're touching my spots where you're going to hurt me and cut it off. Because remember, that's their fears going into being a toddler. So, we try to get it done early. Post-operatively, they usually leave a catheter in it. Because if you can think, the hole used to come out here. They cut the bottom of the penis for it to come here. They fillet open the whole opening to make an opening so that the urine can come out the end. So they put a catheter in there for about a week, 2 weeks, to keep the integrity of the lumen of the inside of the urethra open. We do nothing with it, leave it alone. Now, I'll tell you to do one thing: make sure that catheter is in a diaper, or you're going to have urine everywhere, because it still will come out that awful. So hypospadias is when it comes on the bottom. Now, epispadias is the top of it. Again, I've sent you some good pictures of it, showing you what they do. It could be by the bladder, it could be in all different positions. And that's what I was saying here, that, a lot of the genital urinary tract boys or girls. I mean, girls can have their bladder born on the outside, or boys, the bladder's out, or it's the part of the intestines. And what is our goal with anything? All right, epispadias, hypospadias, they're still urinating. It's not a big deal. We fix it just for the aesthetics of it and for them not to have problems in the future of them not urinating out of the right hole, right? Instead of on bottom or on top. Now, when we're talking about an abdominal wall with stuff now coming out like a bladder or intestines, remember our key thing is to prevent destruction of tissue. It's keep it free from infection. So we would make sure that the tissue underneath the skin of this bladder doesn't get excoriated and that tissue doesn't get infected, because we have to put it back in the body. And it'll go back pretty easily, believe it or not. So again, the treatment, as I said, this thing is born on the outside. It still works. The bladder still works. It's just in the wrong position. So again, make sure that we're watching the intake, the output, make sure that we're looking at protection of the skin, etc. So there's another picture that's a hypospadias, and there's the catheter that we would have in postoperatively. And you can see it sticks out. So make sure we have it inside the diaper. Our job, you're measuring intake, output, checking the wound for infection, seeing that the catheter maintains, and it's just keeping the wound clean. Is it soap and water, or is it something else? All of that has to do with physicians, what they want. And remember, they've had their penis filleted. It hurts. Make sure that they get something for pain. Now, renal biopsies are done when you have these, it could be looking for cancers, or it could be looking for, maybe there's this infection that doesn't go away, and we think the kidneys have this infection. So we go in through the back, and we do pre-medicate for this. And it's going to hurt because they have to cut. If it's an infant, an incision will have to be made. On older children, they can, through ultrasound, find out the kidney and get a needle in and take a little puncture of it. But again, you've gone through the skin, through the kidney, into the get the urine, right? You have to worry about bleeding, and you have to worry about the kidney now leaking urine into the abdominal cavity. So postoperatively, just like a cardiac cath, pressure dressing or a sandbag, because you have punctured the kidney, bed rest 24 hours, just like cardiac cath, right? So we've hurt the kidney. What are we going to be monitoring? Intake, output, and that abdominal pain or tenderness in case blood or urine is filling the abdominal cavity, okay? And again, they need something for pain, get them something. So I've mentioned obstructive uropathy. It could be anywhere, in the kidneys, in the ureters, any vesicle, any sphincter, all the way up. And that's the picture that's in your book, just to show you the names of the compartments. The thing about a kidney, the bladder here, that's a vesicle. That's what they call it. It's a vesicle, a thing that holds fluid. So it's one of the words, like, well, they just say bladder. No, it's a vesicle. So when you talk about vesicle ureter, ureter, you're talking about somewhere between the bladder and it connects to the ureter. There's a kink. There's something that's not right. It could be just reflux. It could be just that valve is not working well enough. So just to, put yourself into the words, hydronephrosis, water on the kidneys, ureter, ureterol, that's all about the ureters. And again, vesicle is your bladder. Now, I do have some students doing nephrotic syndrome as one of their projects, and it's an interesting study. And it is something that when you got it, you got it. It's not like something that you got it from something. No, it's one of those conditions where the kidney says, protein, I don't like you. Oof, I'm getting rid of you. Your kidneys work. Has nothing to do with kidney failure. Your kidneys work well, but it doesn't like protein. So it spills protein out like crazy. How would you know that? Well, the protein would be in the urine. That's the first thing. The second thing is protein is also the name albumin. It's the same thing. So the albumin in the blood, which carries drugs around, is down to nothing, which means there's a lot of free drugs in the blood system, which means your levels are going to be higher than normal. So these children need less of a dose of antibiotics. It's an important concept to remember there. Also, they have a problem with their lipids and their fats. Another thing, because of the lack of proteins and we have fluids being pushed interstitially, you have generalized edema everywhere. And one of the places is even the mouth and the tongue. That's why these children have a loss of appetite. If your mouth was swollen and you kept biting it when you're chewing it or food, you would not want to eat as a child. So these are immunosuppressed children. Okay. They are getting rid of protein like crazy and they are restricting fluids. They're holding on to fluids. So, how do we treat fluid balance problems? Well, too much fluid being held on, salt restriction, fluid restriction, watching intake, output daily weights. Again, big concept, all about fluids right there. So this is for life, and it's something that the children needs to know and to offer what support for the family. If you're in big families and the other kids have a salt shaker, you're going to, I can have it and you can't. So something about teaching brothers and sisters is something I've always done. So nephrotic syndrome, we know that we have to do something to reduce the urinary protein. They give steroids. They decrease the inflammation, and it does decrease the amount of protein in there being excreted. The fluid restriction, one of the ways that we can pull out a little bit of fluids on these children is replacing the protein in the blood. So how do we replace protein in blood? We give albumin, right? Protein, albumin, same name. And there are a couple different types. There's 5%, 25% albumin. And if they get really swollen, what they would do is, of course, start with the steroids, salt restriction, fluid restriction, yes, but they're going to give a dose of albumin, wait half hour or so, and give a dose of a diuretic. And you will see it pull the fluids from the interstitial place into the blood volume, and then they can excrete fluid. That's the one way that we can pull fluid out. So again, how do we manage nephrotic syndrome as nurses? We're monitoring it by intake, output, daily weights, fluid restrictions, and salt restrictions. That's all about fluid. Now, acute glomerulonephritis. This is very similar to rheumatic fever. It's caused by a strep infection. There are two different things that can cause problems if a strep throat wasn't treated completely. So usually you will see these children come in and all of a sudden they stop urinating. You will start seeing them getting swollen and edematous. And because holding on fluids, not urinating, blood pressure goes way up. All right. And you're going to start seeing that periorbital edema because you're getting all of this extra fluid, blood pressures are elevated, headaches, really bad headaches occur from this one. So we really need to monitor those blood pressure closely. Many times they'll give them something for the blood pressure, a medication. They're going to be squeezing whatever urine out. You're going to see blood in it, and you're going to be seeing protein in it. Remember, depending 1 plus 4 plus protein will depend on how severe is this child right now. So the prognosis on these children's glomerulonephritis is if we go ahead, we're going to treat that strep infection. Again, it's a longer term. But the thing is, if we get it and we cure it pretty quickly, that's it. There's going to be no damage. Remember, rheumatic fever, if you already had heart valve damage, you're already going to have it and it's not going to go away. Well, there isn't that here, but sometimes we don't treat it quick enough or that child's body's resistant, they can have chronic glomerulonephritis. So again, daily weights, I and O. These children, yes, it's kidneys. Let's measure the abdominal circumference. Again, nutrition, low sodium, and fluid restrictions, of course. And again, these children are immunosuppressed at this time, susceptibility to infections, hand washing, hand washing. Wilms tumor, it's your kidney tumor, right? We know about this one. African American children, about 3 years old, you see them in boys, and we know don't touch it. We put it here again because it is at kidneys, and it's been a HESI question lately. So just to let you know, big thing, do not palpate abdomen, and it's a renal tumor, okay? Kidneys do have renal failure, acute. Most of the time, believe it or not, is due to dehydration. Acute renal failure in children many times is from dehydration. So you see how intake output on children, as basic as that, are extremely important. Yes, it could be due to disease or obstruction, etc., but usually, as I said, dehydration. Now, chronic renal failure is usually you're born with it, less than 50% of the kidneys working, and it gets worse and worse. It could be due to a congenital, anomaly, or there's other things. I'll go into them. Now, as I said, acute renal failure, most of the cause, severe dehydration, and all the signs and symptoms of renal failure is edema, the metabolic acidosis, electrolyte problems, potassium, red blood cell production, erythropoietin, all of those things are affected the same. And in chronic, we call it uremia. I've actually did clinicals at my hospital. I hadn't worked on the GUGI floor, and I got to work there as a clinical instructor, and that's where their kidney dialysis room was. So of course I'm nosy. I say, so why are so many kids on dialysis? And they said, well, many of our children, it was familiar, something with families marrying interfamilies versus marrying a different family for whatever their beliefs or religions are, and this is one of the side effects. I was like, really? Yes, a lot could be the obstruction, could be just born that way, but that was one that I didn't think about. The other thing, of course, that caused that chronic could be anaphylactic purpura. You have an anaphylactic reaction, it attacks your kidneys, then your kidneys will be damaged. And then remember, lupus. Lupus attacks anything, so it can cause renal failure. We don't think of it that way, do we? They attack all the organs. Yes, it can cause it. So how do we treat it, renal failure? Well, we want to promote that kidney for working the best it can for as long as we can. The big thing is fluid and electrolyte balances. Again, that hemoglobin, red blood cells, will be given subcutaneous erythropoietin injections. We give it here in kidney problems. We give it in cancer when we're worried about red blood cells too, to try to make the body do the best they can. And even though it's hard, trying to maintain a kid as an active, normal life as possible, it's what we should do. Now, one of the things that I learned when I went to the hospital I started at down here, one of the first days I had a little baby on peritoneal dialysis, and I was like, I didn't understand what it was. I had never seen it before. And what was interesting is they were holding a peritoneal dialysis class for certification. So I didn't go home that day after work. I worked nights and I just went to the class and learned what it was all about. Well, what this belief is they stick that catheter. You see that big catheter coming down and hanging down? That's directly into the peritoneum. And they think the peritoneum is like a kidney. So what the goal is that catheter, usually at night when the baby's asleep. So this child can be normal during the day, and when they're sleeping, what they do is cycles of 8 or 10. And the cycle is is that big catheter is hooked up to a machine where there's warm diastolate fluid, and they're programmed in how many mLs am I going to put in that tummy. So usually it's 100, 200, 250, depending on the size of the child. And then there's a still. How long does it sit there for? Could be 20 minutes, 30 minutes. And then they do a drain, 20 minutes, 30 minutes, usually 8 to 10 cycles per night. Now, how much urine output did they have? Well, that drain on these infants just goes into Foley catheter bag. When you measure what came out during the night, you subtract the cycles. If you had 10 cycles at 100 mLs, you were going to subtract 1,000 mLs from the fluid, and that's your output. Now, why don't we do hemodialysis on small babies? We can't. The turbulation and flow of fluids is going to rupture capillaries in their brain. It's too tender, too fragile. So for the first year or two of life, this is how they're going to live. In fact, now in the adult world, instead of sticking patients directly onto dialysis, they're doing home peritoneal dialysis, and it's working actually really well. Our biggest concern is they're going to connect a tube to this other tubing and connecting it, and it must be done under super sterile conditions. What if it's not done under super sterile conditions? You've entered bacteria into the only thing that's working as a kidney. So you have created peritonitis. How would you know you had peritonitis? Well, you might see tenderness, redness, but usually it's a change of the color of the stuff that's going to come out going into the Foley catheter. Because usually the stuff that they're putting in diastolate is usually clearish. So if you're seeing something come out and there's brown and tan and something colored, that's when number one, you're going to call the healthcare provider now. And they're going to say, give an antibiotic. But remember, the doctor has to order the antibiotic. We know that it's going to be that. And it's great. I've seen this done beautifully on this little boy with prune belly. It's a great diagnosis too. All has to do with kidney failure. That mother did dressings on that peritoneal catheter better than I can. And I'm actually pretty OCD when it comes to neat, tidy dressings. So, and he never, ever, ever, little Willie never, never, never had an infection. And finally, he went for a kidney transplant. So, what is acute glomerulonephritis? What is it? Why? How?
B.
A.
Acute glomerulonephritis is caused from a streptococcal infection. Okay? Rheumatic fever and acute glomerulonephritis.
Can
So
it
let's
rise
go.
either? Well, yeah, okay, never mind. Yeah.
Good,
Same
good.
thing.
Go.
No, like the UTI can also cause glomerulonephritis, no? Like if whenever it starts there, it keeps ascending.
It can, but glomerulonephritis, that would be more of a, end up being chronic because they were your kidney damage. This was due to the infection. We clear the infection, then that goes away, and your kidneys will be okay. Yes, there's things that can cause it. You're right, Sam. Yes, in another way. So remember GI, mouth to anus, and everything in between. It's the way I describe it. Remember, where's all your nutrition absorbed? Mouth to anus. So we talk about vitamins, minerals, and all of those things. We know that there's always going to be worry about nutrition with children with cancer, HIV, any immunosuppressed condition. Remember, cystic fibrosis has that component of small intestines having trouble digestion. Celiac disease, another one, right? We'll go into it. And of course, low birth weight. There's not a lot of area to put nutrition in there, and they need good nutrition. So celiac disease. This is another small intestine problem. And what happens is the small intestine has a problem because it doesn't absorb fat. And what happens when you eat fat, the intestine doesn't like it, and something called steatorrhea is the result. And it's basically a stool that is pale, bulky, and it is quite malodorous. Okay. What happens if you eat a lot of fat? Well, you're going to have a lot of gas too, especially if it's not digested. Your abdomen's going to be quite distended. And if you're not digesting fat, the highest calorie of any sort of nutrition, right? That's at 9 grams. You're talking protein and carbohydrates at 4 grams. This is, over twice the amount of calories. So again, it's going to be all sorts of general malnutrition. So how do we treat celiac disease? Well, celiac disease is all about gluten. And gluten goes in there and it upsets the lining of the small intestines and it creates the problem worse and creates I've seen little children in so much pain, bending over, grabbing their abdomens, and it hurts. How do we treat that? Well, at that point, they get a steroid to calm down the inflammation, but it's a constant monitoring of a gluten diet, low gluten, no rice, no wheat, rye, barley, or oats. So think about all of the things with breads, grilled cheese, breaded chicken nuggets, spaghetti noodles, macaroni and cheese. Oh my goodness, now you've talked everything the kid likes, right? So there are ways, and today we're luckier than ever because there's a lot of different alternatives. In fact, you'll see gluten-free packages of even potato chips out there. So we didn't 30 years ago, children didn't have that. So we've made lots of advances. Rice flour actually is a great alternative, and rice is that alternative that should be put in. Now, we start adding foods to children about 6 months. And at 6 months, we have this child who we add one food at a time every 4 to 7 days, and we're looking for allergic reactions. Remember, it could be as simple as a rash. It could be as much as anaphylaxis. I've never seen it go to anaphylaxis. Usually it's more abdominal distension, abdominal cramping, vomiting, diarrhea. Diaper rash, believe it or not, is one of the ones that I see a lot of it. We know that there are children, for instance, with sometimes you've learned, oh, they're allergic to lactose or they're allergic to this. Can we give that to the child in a different way? So this lactose intolerance, well, let them have vitamin D and calcium deficiencies, right? So we might have to look at how else are we going to give vitamin D? How else are we going to be giving them calcium? And these are things we have to think about. GI dysfunction, there's all different ways. You don't eat, you don't get the nutrition. Of course, failure to thrive. And of course, if they're really young, cognition is they're not going to be developmentally where they should be. It could be just that constant spitting up. If you think about it, constant spitting up, how much nutrition are they losing? So nausea, vomiting, diarrhea, constipation, abdominal pain, all of these things are problems with the GI tract. We also have some children who have things like DeGeorge syndrome. And DeGeorge syndrome has a problem with eating dysphagia when they don't swallow correctly. So again, now you've got another thing that we have to work with in order for them to get nutrition. And always remember fever. You're burning up all of your insensible fluid loss, right? So we have to make sure with fevers to make sure we keep replacing it. Dehydration, we know it happens from many different ways. Remember fever. That's one thing we tend to, oh, that kid had a fever. Did we give extra fluids? Vomiting and diarrhea we could see, and then if they're urinating like crazy, of course. And then if they gone into things like ketoacidosis, diabetes, DKA, of course, that's why we give boluses of fluid there. And of course, burns. So dehydration. I love these two pictures because they really show two children dehydrated. And what do I see in them? Well, the top picture and the bottom picture, I see sunken fontanelles and it looks like they're just sitting there, sitting up at rest, and it's sunken for no reason. Look at the color of the ears and the nose. Look how pale they are on that child. Overall color is crappy, isn't it? That's some things that before I see anything, let me check a heart rate. Let me check a blood pressure. How many diapers has this kid had wet? And the biggest thing with dehydration, kids and infants, they cry, right? Especially when somebody else touches them. Well, they're crying and there are no tears. You know how sad it is to see a little baby crying and there's no tears coming down? You know how dehydrated. So what do? How do we treat dehydration? Well, if they look like these children, you're going to start an IV, and at that time, you're going to do a basic metabolic profile. We want to look at potassium levels, sodium levels, right? We want to see. Also, we're going to be giving bolus of fluids. Remember two things. You never bolus fluids with potassium. You never bolus fluids with glucose. And you can't add potassium to an IV until you either have that potassium level back or until the child voids. Okay? Very key things. If we gave potassium, they hadn't voided, we could be sending them into very high potassium levels. So it's better to look and check than it is to try to work ahead when you shouldn't. Now, kid goes in, admitted dehydration. How do you know? Is our treatment working? Well, how do you measure fluid? Intake, output, daily weights. Well, let's look at the weight they were when they came in. 3 days later, how much do they weigh? It better be more because now they built fluids. Again, I'm trying to get you to think, how do you check these things? So intake, output, I've said it a couple times. How do you measure intake and output? Of course, urine, stools, vomiting. Say they're profusely sweating. If we needed to, we could measure it. I've never, but you could. Looking at vital signs, elevated heart rate, decreased blood pressure, tenting of skin is a big dehydrated thing. Again, body weight, did it go down since yesterday? This kid started vomiting. Those fontanelles are great in young kids. You have like the first year of life to have that as your, are they dehydrated or not? Let's feel that there. And of course, sensory alterations. A child who doesn't have fluid in the body is not getting fluid to the brain, which is oxygen. So they're going to be a little bit altered. They're not going to be alert like they normally are. So diarrhea, all different types. Our goal, diarrhea, is to rehydrate. So what do? Well, if they look like those babies, we're going to give IV fluids. If a kid's sitting there looking like these two, yeah, they look, a little bit, like the girl on the right, she look a little pale, ears, maybe the lips aren't too great. Maybe she could go with an IV. But the girl on the left, you can see she's alert, colors are pink, let's give her oral. Remember, in diarrhea, if you don't start to give food back, they're just going to have nothing to make a stool with. So it's going to be liquid continuing out. So reintroduce the diet slowly. Again, no spicy, no greasy. They used to have this thing called a brat diet. We don't say that anymore, but it's the perfect things. Bananas, rice, applesauce, toast. Those will bind them up and that will start, holding that stool down. The other thing that they give for diarrhea in the hospital, and it's not in your book, it's lactobacillus. And we give it once a day until the stool is formed. And it works. Now, constipation in children. Constipation in children many times is all about their stress levels, their cycle, right there. Children, the only thing that they can control is their stool. Did you know that? They can control it for 10, 14 days and not have a stool. And many times they're looking for some sort of attention or something stressful has happened in their life. Their grandmother moved away, or their dog died, or what, kids, what would bother them? So they want extra attention. So they do hold their stool, and it happens more than you really imagine. Now, important concept right here, and you're going to see this in questions mixed up. So at birth, A child should have that sticky green, mucousy looking stool within the first day, day and a half of life. I say up to 2 days, okay? If they have not passed any stool, it is totally unusual. So usually there are conditions that could happen. So hypothyroidism, I've already told you about. So we'd be checking thyroid levels. Cystic fibrosis. Remember, it's constipation, right? We would test, even if we didn't know, we'd be testing for CF. We'll do a sweat test, right? And then we're going to go into what a Hirschsprung's is, and we'll go that further. And then, of course, if there's any narrowing or completely no opening from the intestine. So stool should be passed. If not, there are those big three things: Hirschsprung's, hypothyroidism, cystic fibrosis, or then it's just structural. Now, constipation during infancy. Most breastfed infants do not get constipated. Believe it or not, it's more with the formula fed for whatever reason. We know that sometimes the intervention is as simple as changing their diet. As they get older, we can introduce things, whole grains, black beans, believe it or not. You know, being from South Florida in the Hispanic population, I thought that was pretty neat. It was part of the book, so I put it there. But remember, constipation, we do not treat with enemas. We do not treat with stool softeners. The one thing we might do is add a little bit of a type of stool softener, like a Metamucil type thing that we do. And that's the last thing. It's fluids first, right? Always. Now, pinworms, roundworms. Pinworms is a child who is complaining that their rectum itches like crazy and they're not sleeping because they feel this itching in their anus area. So what do? Well, number one, we got to find this worm. So you take a flashlight, go underneath the covers with a piece of Scotch tape, and just put it on their anus, push it down, and pull it off. And they're itsy bitsy, tiny little things. Take it, put it in whatever we have, take it to the doctor, and we can get medications for it. How do we prevent this? Well, what do little boys and girls like to do? They like to go outside and they like to play in sandboxes, get in the dirt, right? Riding their bicycles around, toys. It's all up into their nails. So the one thing they say is just cut their nails short. And if one person has it, check the whole family. They all will have to be checked, or all will have to be treated. Children do get ulcers. You have these little children, or these worrywarts, as I call them, and they worry about everything, and it's real. And again, first line treatment. Now, ranitidine's in your book. We know it's now Pepcid. They don't do ranitidine or Zantac anymore, and that's a newer thing on the market. But again, all that does is reduces gastric acid. Again, looking at diet. Problems with the liver could be due to many different things. What we need to know is no matter what the liver damage or chronic inflammation is due from, we know that we need to, with children, make sure that they're getting proper diet. So high protein, high carbohydrates, because what does bile of the liver digest? Fat. So again, low fat diet, or you can have these big bellies, abdominal cramping, and gas, and it's painful. So this is another one. Fat problem, just like cystic fibrosis, right? Just like your celiac, different things that we do, but low fat diet will help prevent the stomach tenderness and things. So high protein, high carbohydrates, getting that caloric in there. Now, there's something called a biliary atresia. A new slide I added in because I'm seeing more questions pop up on this one. And all it is the duct that goes from the liver into the common bile duct, which is going into the small intestines. It's an A. It's not connected. It's not working. Your liver is there and the bile is just backing up, backing up, backing up. and it's not going anywhere. What happens if we don't get rid of bile? Well, what happens when a patient looks like with cirrhosis? The yellow eyes, right? Abdominal distension, tea-colored urine. You're going to see very clay colored stools, and these children need surgery. They've got to reconnect the liver to the common bile duct. Now, here's that other thing that causes your constipation or no stool in the first 24 to 36 hours, and it's called Hirschsprung's disease. Now, that's a picture of the ascending, transverse, and descending colon going down to that little skinny point called the rectum. That area that's enlarged is denoting an area that has no nerve endings. So aganglionic. So there's no peristalsis. The fluid, food, whatever goes there and it just fills up. Now, sometimes so much gets in there, you might see that bottom rectum have a little squirt of ribbon like stools, just like you're doing icing on a cake type thing, that you might see that type, or you may see nothing at all. Always remember Down's children. Again, this is something else. We have hypothyroidism. We have leukemia. We have Hirschsprung's disease. They're more likely to get all of these things, okay? So how do we treat Hirschsprung's? Well, no stool. We do an x-ray. We do a biopsy, find no nerves, and we need to take that dead piece or no nerve ending area of the intestines, need to get rid of it. So we could do two things. We can take it out and reconnect. Okay, it's a pull through thing. Or we need to put in a colostomy and then usually, again, try and before they're potty trained to reconnect that, give that smaller intestines a chance up to that. Remember, whenever we're working with Hirschsprung's and post-op surgeries, we should not leave the rectum alone. Don't touch it. And always we have to rest that area. And it's usually 2 to 3 days, giving that intestines a chance to get some good, healthy bowel sounds in there. Appendix, just like your adults. You know, acute appendicitis kid comes in, they're very evident. They're walking down the hall into their room. They have their right hand underneath their right inguinal area bent over, and they're hopping a little bit on the right side. Classic appendix. So when we see that, we're going to see that rebound tenderness, McBurney's point, right? All of that. So what is our job? Well, we've determined it's appendix, they're in pain. Make them NPO, they're going to go for their ultrasound, and then we are going to get them up to the OR. Now, when they are in the OR, you're going to start an IV, right? Before they go to the OR. We always give a pre-op antibiotic. It's just one of those things to be sure. Remember that cecum area is really infected there. And of course, any IVs, keep them well hydrated and whatever meds they have to give for sure. Now, all of a sudden before they go to the OR, oh, the pain's not there anymore. I don't need to go to the OR. Well, that's dangerous. When the pain goes away, their appendix has ruptured, and now you have flaming peritonitis. So this child will still go to surgery. They'll remove the pieces of it. They'll clean out the abdomen as well as they could, but you need to know nursing care. They need to be made NPO because you have spewed, or they have spewed, all of this toxic liquid into the peritoneal cavity, and it's irritating the intestines, and it's angry, and it needs to rest. So we do two things for the intestines, NPO, and we have an NG tube sucking out any secretions. Like the stomach always is producing stomach acid, right? So this is something absolutely that we would keep that away. I mean, our priority absolutely is antibiotics. You know, there's a raging infection. So NPO, IV fluids, your priority is your antibiotics. we're going to be looking at lab values. What am I looking at? Well, you had an inflamed appendix that burst, and now you have an infection. I'm watching neutrophil counts. I'm watching white blood cell counts. Where are they? Are they coming down with the antibiotics that we're on? And the one thing we forget is this. This has been a dirty procedure now because all of the infection was inside this wound. So those wounds, when you close it back up, it's infected areas. The chance of them coming apart or dehisce is greater in this case. So monitor that wound. It will dehisce. So please watch it very, very closely. One of the things they say with these children, because their tummies hurt, get them up, medicate them for pain, get them out of bed. Yes, get them ambulating, a couple times a day. And then blowing bubbles. Or I used to do all different crazy things with the kids to get their lungs moving for them. But I would always have bubbles and they'd be blowing them and they're taking a deep breath and that helps. And sometimes those little pinwheels that go, you blow on those. And again, they're great for their lungs. Now on omphalocele, this is when the intestines, liver, abdomen, the stomach, whatever, gastroschisis, omphalocele, something that's supposed to be inside was born on the outside. And there's like a covering. That's your peritoneal sac that's covering it, okay? Usually these kids, everything's working in there. Only problem was born on the outside. So again, what is our concern? Well, we got to keep that free from infection. So again, cover it with a warm but sterile saline dressing. Keep it moist. Protect the integrity of that tissue. This is a child which will be on their back. You cannot put them prone, okay? And they will be in a warmer. So they're getting warmth through that. And you can't swaddle them up because you're going to be constricting that abdomen. Antibiotics, all preventative, making sure no infection. And because their stomach is in the wrong place with the intestines, NPO, and we'll be giving IV fluids to these children. I've seen many of those in my career, believe it or not. They'll take and put it in a tent, as we call it, and slowly they'll come in and push it in. And about the third or fourth day, they've made enough space to be able to do a closure. And they do well, not usually any problems. Intussusception, the intestines suck into each other. It's called a
Question
telescope. Yes.
about that one, because it's kind of like evisceration to me for treatment. Uh, do you keep changing the cloth or do you just keep it moisture?
No, the physician comes every day and does it. When we get them at birth, they'll tell you, put a sterile one on. From there on, they have to manipulate the inside of the abdomen to squish and make room and try to stick some in there. That's what they do, and sort of smush it down to get it there. They do that. But the first one, it's us. We have the saline dressing, we put it on top, and then the surgeon will be called, and then they take care of it, and it's theirs. And we just monitor it.
Copy.
No, that's a good question. Thanks. So intussusception, what do you see? These kids, the first one I ever saw, kids screaming, legs up and down, crying, back arching. 5 minutes later, the kid's walking around the room and he's fine. What happened is the intestines got sucked in and it hurt. And then all of a sudden it came out by itself spontaneously. And that happens like that. Sometimes it gets sucked in and it won't go away. So that one will need some sort of intervention. What you're going to see is a current, like a goopy jelly with blood in the diaper or in the underwear. You might see that there, okay? So we're going to do an ultrasound. We find it. If this kid all of a sudden passes a stool by themselves, then we know the intestines is working. Those are things that we will tell the doctor about. But usually we can just pop it out, send them home on a high fiber diet, and they do all right. Sometimes you have to take that piece of intestines out, but I've had one in the multitudes of those that I've had. Now, Mecker diverticulum. It is, they say, the remnant of the fetal mesenteric duct, basically. The insides of the intestines, small intestines usually, has like an outpatching, like a little tab, skin tab thing. And inside is a big blood vessel. And somehow through the normal passages of stuff, it rips, it tears. So minimal, if any. They call it painless rectal bleeding. And it's, it's a big vessel that was torn in this little duct. And you're going to see, you can see a toilet full of blood with the stool. And we treat it. We have to go in there and remove the diverticulum, and they do okay with it. But it's just that painless rectal bleeding that they see if we let it go on, other things can occur. IBS, ulcerative colitis, Crohn's disease. One of the things, ulcerative colitis, that's when you're going to see that profuse diarrhea with, treating it with diet, your IBS. Some of them, yes, absolutely. Some with steroids. Some of them even go to the point where they put them on biologics like Humira. Their bodies, making their intestines so irritable. Again, it's sometimes a medical treatment works with a good diet. Sometimes they'd have to take pieces out, and could be pieces here and there through their lifetime. Again, nutritional support. What are you going to feed them that doesn't hurt them, but still, gives them the nutrition they need? Short bowel syndrome. It's an interesting one where some part of the intestines died. Now, my little Jessica is a triplet cardiac child, second stage surgery, came in, hypoplastic left heart. She was on a big breathing machine called an oscillator, and she had an NG tube in, ND, down duodenum with just a little bit of fluid going. Well, her stomach didn't like it, and her intestines exploded. They took her to surgery, and 56, I think was the number, centimeters of her small intestines was removed. That's what short bowel means. That means there's hardly any area for the body to suck in the nutrients it needs, okay? So how do we treat these things? Well, again, these kids probably will have hyperalimentation and lipids at nighttime, tube feedings if they want something by mouth. It's like this whole constant, let's feed them, let's feed them. Little Jessica, I met her from that 6-month time as an 18-year-old, one of the last patients I took care of when I left the ER. She was a skinny, tiny little thing, but she lived through it and she was eating normally. And I asked, of course, because she was part of my kid. Now, necrotizing enterocolitis is what I just described to you. Something happened, maybe a feed, the intestines didn't like it, and the intestines burst, spewing contents into the abdomen. Necrotizing enterocolitis. Hernias can be anywhere, and they're going to be okay unless they're hard and they're painful. And I like pushing those belly buttons in, nice and soft. Those are great ones. Hernias can be anywhere, but if it's twisted, if it's tender, painful, it's the intestines is going to die. They need to go to surgery. You have times where you have an anal rectal malformation. That means no anus. I think it's one of the reasons why we check for temperature on at birth. There's all different fistulas that can occur. I've seen some where I've caught that I've seen urine coming out of a vagina, stool coming out of a vagina. You might see some different things. So sometimes it's our nurses' eyes that see these things and get them corrected. Children put everything in their mouth, everything. Again, it's principles of emergency treatment is we don't make them vomit. We don't believe in ipecac anymore. Call your poison control numbers, and try to keep our houses as safe as we can. Vomiting could be all different ways. It could be just a little dribbles, or it could be, profuse. And I'll go through what that is. But again, with vomiting, what do we do? Like diarrhea, we're going to do an IV. Or a lot of vomiting. Do that profile. And we're going to be giving IV fluids, no dextrose, no potassium till we see it. Now, reflux is something kids get. It's a very common thing, this little spit up, but a lot of spit up, through all their feeds, right? A little bit sometimes is okay, but, if it's all the time, again, they're not getting their nutrition. So how do we help keep that food down there? Well, breastfed or bottle fed, we can put a little bit of rice cereal in the formula or breast milk, and that thickens the formula or the milk to keep it down. That's the first thing we do. Also, we will be giving them instructions, parents, not to overfeed, how to burp well, how to sit when they are done. Also, older children can have reflux. How would we know it? The signs are, imagine this is the food coming up. They're going to have this chronic cough, chronic cough, chronic cough. And that's telling you they're having these little mini aspirations. And they'll have that pain, right? At their xiphoid, right? That's their heartburn going on. So older children having that, of course, changing their diet, not overeating, medications if needed. But sometimes it's so bad we have to do something called a Nissan fundoplication. That's usually done for gastrostomy tubes. And what it does, it clamps over the top of the stomach so you cannot vomit. And it is surgical, and it is permanent, and it keeps the food down. Now, hypertrophic pyloric stenosis, you'll always see tests on this, always. This is when the valve that empties the stomach into the small intestines, the pyloric sphincter, is hardened and hypertrophic, okay? It doesn't allow food to go down. So this child will come, they're usually 7, up to 3 months old. They say 5 to 7 days, up to like 3 months. And this child, you'll ask, they say they're vomiting. Is it drooling or is it across the room projectile? Across the room projectile is pyloric stenosis. That is, the food goes down, it sits, and all of a sudden the stomach can't take it and they vomit across the room. So how do we treat this? Once we realize it's a surgical problem, they're going to the OR today, make them NPO, start IV fluids on them, and do not let this child eat anymore. Cleft lips, we know cleft lips could be one side, both sides, both of the bottoms. Again, it's protecting their airway as we're feeding them. And always remember, we try to get this stuff done. The lip we try to do by 2 to 3 months to give them the seal. And later than that, 6 to 12 months, we try to get before they start to talk. Because remember, speech will be affected by it. There's all sorts of feeding ways, squeezing the breast, using special bottles, all of these things that have been done well with. And then esophageal atresia, tracheoesophageal fistula. So we've had your pyloric stenosis where you're going to make them NPO, start an IV because there's not vomiting, there's no aspiration. This is at birth. You'll see a child choking and gagging because they're swallowing their own spit. It's going down their esophagus, right across the fistula, into their lungs, and now you're having all of these aspirations. So this child, NPO, this child, elevate the head of the bed, suction at bedside, and we're going to be giving antibiotics before surgery because they're having many aspirations. You want to protect from them from pneumonia. Well, we didn't get to the cahoots. I will send it to you. We went right to the end today. A lot of stuff on that. Anybody who needs any extra with that, let me know. And I'd be more than willing to get with you. Any questions?